Welcome back to the Clinical Athlete Podcast. If you're not familiar with Clinical Athlete, we're a network of healthcare providers, students, and coaches who specialize in the management of athletes. You can find your nearest Clinical Athlete provider at clinicalathlete.com. We also have a forum where we discuss and share ideas and resources related to sports med, athlete rehab, and performance. We don't just discuss, we do other things. So to join the forum and for a potential listing on the Clinical Athlete Directory and for all upcoming seminars, webinars, and events, details can be found on the website. We got lots of the powerlifting courses and weightlifting courses coming up, and great webinars and online courses as well. So check those out. This podcast can also be found on the website along with YouTube, iTunes, Google Play, Spotify, Stitcher, and iHeartRadio. And a review is always welcomed and appreciated. My name is Quinn Hennick. I'm a doctor of physical therapy in Orange County, California at Clinical Athlete Newport. I'm joined by Jared Maynard, who is the Clinical Athlete Continuing Education Director and Coordinator and a physiotherapist at King Physiotherapy and Foot Clinic in Ontario, Canada. He's a certified strength and conditioning specialist and runs an online powerlifting coaching company and is a competitive powerlifter himself. What's up, Jared?
Not much, man. How's your day going?
Day's going well, man. I spent the morning at the beach, actually listening to a podcast, and I walked up to my office, and now I'm talking to you guys. It's been a great day.
And I'm just happy to see the sun up here in Canada land.
Canada land.
And we got John Flagg, who is an athletic trainer and wellness director at Orthopedic and Sports Physical Therapy in White Plains, Maryland. He is the powerlifting, weightlifting, and strongman coach at 301 Strong, also in White Plains, Maryland, and the owner of Rebuild Stronger, an online coaching platform for strength athletes. He's also the clinical athlete provider and lead instructor of our newest course, Clinical Athlete Powerlifting Certification. John, how you doing?
Doing well. We actually have sun for the first time in a couple days, so I'm jealous of your beach capades.
There you go, man.
In California.
Beard's looking strong. When's the last time you oiled?
2 days ago.
Nice.
There's a nice soundbite.
Yeah. And we welcome a very special guest, physical therapist, PhD, and assistant professor at the University of Alabama at Birmingham, UAB, Matt Ithurburn. Matt, thanks so much for being on the show.
Yeah, guys, thanks for having me. Happy to be here.
We're really excited. So Matt just came out with some new research on the ACL, which he's a lead author on. But before we get into that, can you tell our 6 listeners a little bit more about yourself and what's led to your current research tracks and interest in the field, and obviously, ultimately, what's led to the pinnacle of your professional career now, which is being on the Clinical Athlete Podcast?
Yeah, this is the pinnacle of my career, I can say confidently. So, I mean, you kind of gave the brief background, but I have a clinical background in sports medicine, PT, and kind of navigating my clinical practice. I was at Ohio State and saw a lot of patients with ACL injuries, and just felt like we were missing something in our rehab and our decision making as far as how to effectively get these patients back to sport. And that was really a lot of what motivated me transitioning into doing my PhD, to try to take a scientific, kind of clinically relevant scientific approach to these questions. So I did my PhD there at Ohio State. I worked with Laura Schmidt and Mark Paterno primarily, who are both the lead investigators on this project that from the paper that we'll talk about today. And so I was there, did my PhD there, mostly focused on some of the relationships between strength, movement patterns, and outcomes in young, primarily high school age athletes after ACL reconstruction. And then I've been down here at UAB for the last couple of years.
Did you get your PhD at Ohio State?
I did, yeah.
I was lucky enough to meet Matt at CSM this past year, but your research, I mean, if anybody go on Google Scolar and just look at the citations list, you've just been putting out some really, really relevant stuff, just clinically relevant stuff. And you just came out with the latest paper in the most recent issue of JOSPT. And the title of the paper is Knee Function, Strength, and Resumption of Pre-Injury Sports Participation in Young Athletes Following ACL Reconstruction. And you were the lead author, Matthew Longfellow alongside you, Stacy Thomas, Mark Paterno, Laura Schmidt. So that's a great cast of authors there. The purpose of the study was to examine differences in knee function and strength at return to sport clearance between young athletes, and these are like high school age athletes, who successfully resumed, so 3 groups who successfully resumed pre-injury levels of sport following ACLR, those who did not resume pre-injury sport participation following ACLR, and then those who sustained a second ACL injury over the year following their return to sport clearance. So you guys were looking at how they tested at return to sport, and then following these 3 groups kind of along that first year after returning to sport. So I'll throw it back to you. What made you guys ask this question and look into this specifically?
Yeah, that's a great question. So, I mean, there have been some studies and some previous work that have looked at both return to sport outcomes. So generally, like when we kind of compile how people do over time after return to sport, there have been several studies that have looked at this, as well as trying to identify factors that predict who, are successful over time versus not, whether that means that they return to sports participation or, they sustain a second injury or something along those lines. But what we saw in the literature and looking at these previous studies is that usually the cohorts that were evaluated were fairly heterogeneous. So they had kind of a wide range of ages and previous activity levels, or they were in very, very specific patient populations, like professional athletes in a specific sport. And so we were kind of curious to see in our cohort, which again is a study that takes place at Cincinnati Children's Hospital, and primarily includes high school age athletes that prior to their injury were participating in cutting and pivoting sports. So level 1 and 2 sports, soccer, basketball, football, lacrosse, sports of that nature. And so we wanted to know in this kind of defined age group of high school athletes, how they did over time. And if they were similar or different compared to what we know about either the general population of people after ACL injury or some of these very specific kind of professional athlete groups. So that was kind of what motivated us looking at this in our cohort. So,
what were you guys thinking that you were going to see here? Can you walk us through some of the methods, the 3 groups that you were looking at, the testing that you guys went through, and then what you thought you were going to see?
Yeah, sure. So basically we, to give an overview of the design of this study, we recruit and enroll patients after ACL reconstruction at the time that they have received return to sport clearance. And so this comes from both their orthopedic surgeon who did their ACL reconstruction and whoever was involved in their rehab. Most of the time this is PTs. In some cases this was athletic trainers. So basically once they've received that verbal return to sport clearance, we test them within basically 4 weeks of that time point. And so that's when we enroll them in the study.
And you guys did the testing? Sorry.
We do the testing,
okay,
yeah. So we do the testing in the lab. And the testing so this study started in 2007 and is still ongoing. And so we enroll them the time that they've received return to sport clearance, and then we follow them over time out to regularly 2 years with regular kind of check-ins in between that period of time. And what we were really curious here was if we test them at the time of return to sport clearance, so we evaluate different measures of their self-reported function, how they feel that their knee is doing, measures of their muscle strength, and then also some functional performance measures, single leg hop tests primarily are what we evaluate. And so if we test them at that period of time and then we track them over time, do any of these functional strength or performance measures differentiate these kind of outcome groups over time? So I think something that's a little bit unique about this study is that we have no influence over when these patients get cleared to return to sport, what factors contribute to what went into that decision, whether objective criteria were used or not, or considered at all. But we really want to try and kind of evaluate the current state of clinical practice around these patients and how they're doing, and to kind of characterize them over time. And so, even though these participants were cleared to return to sport and all of them report planning on returning to level, like their previous level of sport, level 1 or 2 cutting and pivoting sports, we don't really know if they do or not. And so that was a first question was, how many of these high school age athletes actually returned to the same level, which we evaluated with something called the Tegner Activity Scale, which is a 0 to 10 scale, 10 being kind of high level or competitive national level sports participation, and then subsequent categories all the way down to 0, which is basically sedentary or injury or disability. And there are levels in between. But there is a range from about 6 or 5 to 10 in which people are participating in sports, but at different levels of recreational participation versus competitive level. And so we use that as our marker for when they got to a year later after their first testing visit. If people were at the same level or higher compared to where they were prior to their injury, we categorize them as successfully kind of resuming and maintaining their pre-injury sport participation. Those that went down, we said they were not successful. And then we also had that third group, which were the young athletes that returned and had a second injury in either limb prior to that 1 year point, which is a pretty good chunk of this cohort. And so, yeah, that was basically kind of the design and the question there. So,
what did you think you were going to see?
So, I mean, I think our hypothesis going into the study was that the group that successfully returned, would have better strength, better functional performance, and better self-reported function at the time of return to sport. So they're basically, higher functioning at that point in time, and they're going to be successful over time. Whether that meant higher absolute performance or higher, more symmetrical performance, which is something that we can discuss based on the findings of this paper. We evaluated both, but that wasn't exactly what we found in this study. So
yeah,
this cohort.
I want to get into that. And just before that, you mentioned that it was interesting in the study, you guys didn't have control over who was making the decision of return to sport. You just kind of took them at that moment and within 4 weeks, of the decision. But if you look, for people following along here on the actual study in table 1, the time from surgery to return to sport clearance was not different between groups. So that was good. It was all about 8 months, give or take 1 or 2 months. So the criteria, we don't know what was making the decision, but at least we know that the time from surgery was about the same. So I thought that was pretty good. So yeah, you guys hypothesized that, it makes total sense that the group that has a successful return to sport will just test better subjectively and objectively. What did you guys actually find?
Yeah, so I can I'll just give kind of an overall summary, kind of going through each measure. So we compared the 3 groups. And so to measure self-reported function, we used the questionnaire called the KOOS, which is the Knee Injury and Osteoarthritis Outcome Score, which is used often in patients after ACL injury. And so we compared across the different subscales of that measure, which measure different constructs of knee-related function. We found no differences among the group in terms of their self-reported function at the time of return to sport. When we looked at their strength, so we tested quadriceps and hamstring strength using isokinetic dynamometer. We tested at 2 different speeds, 180 and 300 degrees per second. And when we looked at their absolute normalized strength in each limb, involved limb and uninvolved limb, again, we saw no differences among these 3 groups. And then lastly, we also looked at symmetry measures for both for strength, and also found no differences among the groups. So the only place that we found differences between these or among these 3 groups was actually in their absolute hop performance, which all the 3 hops that we tested, we just looked at the 3 single leg distance hops. So the single hop, the triple hop, and the crossover hop. And we took the absolute distance that they jumped on each leg, and we normalized it to or divided it by their height, anticipating that people that are taller or that have longer legs generally jump further, at least as a way to kind of try to level the results between these 3 groups. And what we found was that both the group that successfully resumed sport over that year and the group that had second injuries jumped further than the group that wasn't able to successfully resume or kind of maintain their sports participation over that first year. And so that was based on absolute performance on both limbs. And then the successfully resumed group also did jump a little bit further on a couple other hop tests, the crossover hop and the single hop. where the second ACL injury didn't. But generally speaking, what we find is that the two groups that it seemed went back to the same level of sport, even though one of them included people that had second injuries, just jumped further or performed better on each limb. And so that was kind of the main takeaway of what we found. So no symmetry differences across these measures, both quad and hamstring strength and hop test performance, which was contrary to what we anticipated and based on what we know from the literature.
This is one of those where we just want to ignore it. Like, it doesn't go, it's like, it makes sense. So, the group that had successful return to sport jumped further. We'll talk about limb symmetry indices. I think you had some really interesting discussion there, but at least they jumped further. That makes total sense. Oh, wait, the group that tore also jumped further. Crap. So it's like, be a better athlete. Wait, don't be a better athlete. Talk to me a little bit about what you make of the results, or what questions now can we ask for, furthering this?
Yeah. I mean, I think there are a few points that come up here that are important. So if we kind of focus on, the lack of differentiation between the second injury group and those that were able to successfully return to and maintain over that first year. So both of these groups generally jumped further on both limbs and didn't differ across any measure. And so what that might speak to is that in both of these groups, we know very little about the contributions of kind of overall underlying athleticism to successful return to sport. So we take a very clinical approach to our assessment of these patients. But there may be just underlying athletic skill-related factors or performance that enable people to go back after an injury that I don't know that we do a great job evaluating or I don't think we have a great understanding of right now. And so, in theory, if both of these two groups that, had at least adequate enough knee function to return and also were good enough athletes to return at their prior level to competitive sports, they both are experiencing exposure to these cutting and pivoting sports, which are a primary risk factor for having an ACL injury. And the lack of differentiation between them, I think, speaks to, I think it's a challenging question to answer to say, how do we differentiate these groups? Again, this is just one cohort. And there are other studies that have found risk factors for a second injury that we can incorporate into our clinical decision making, including strength, symmetry, and other factors. So I think what it speaks to is that we need to do, just continue to try to develop and test these return to sport decision making paradigms and figure out how we can mitigate risk in these young athletes. I think another thing to consider here too is that we know that movement strategies or movement patterns are related to risk of primary and second ACL injury. And as a part of what we tested, or at least what we evaluated in this study, some measure of movement quality or movement, pattern wasn't a part of what we evaluated here. And so that may be another important contributor for second injury risk. And so again, that, having a kind of clinically accessible movement assessment for these young athletes may be another piece of this puzzle too.
That answer makes a lot of sense. I'm curious if you were in the position of being a clinician working with one of these athletes. Let's say you've laid out the game plan in terms of what rehab's going to look like, and they've done well. You've been measuring these sort of metrics throughout the process, and they've met these sort of return to play criteria that are based on the studies that we have at the moment. And they say, all right, so I'm good to go now, right? I don't have to worry about it. We know that fear of reentry is a pretty big predictor of reentry. So what do you think might be a reasonable thing to say to that young athlete in that situation?
Yeah, I'm glad that you bring up fear of re-injury, or kind of these psychological kind of readiness constructs. These are really important, we know from the literature, as they relate to return to sport success. But there is also some early evidence starting to show that they also are related to second injury. And so, I think we don't fully understand right now how psychological factors, whether they be fear or confidence, are those similar? Are those different? How do those relate to risk of injury or success? They may have opposite effects. So I think we don't really know this, but my intuition is that there may be some healthy level. I don't want to say healthy level of fear, but in patients that are very confident, but maybe aren't physically ready or biologically ready from a healing and recovery standpoint, may be at risk, just like maybe those who are highly fearful but right. return. And maybe these are working by different mechanisms that we don't really understand right now. Sure. But we definitely know that that psychological factors play a big role in this process, no doubt. And that isn't something that we measured in this study that we tested, at least at the onset of the study. So I think it's a really good discussion to have.
Well, as you brought up the healthy level of fear that we might otherwise name in a minute, I think that makes sense, and it brings to mind that sort of U-shaped curve of estimation of one's ability versus actual ability, and how if we overestimate our ability compared to what we can actually do, then performance usually ends up suffering, versus if we underestimate what we can do, then also we have poor performance. So that sort of ideal place to be is somewhere in the middle, where we're more or less in tune with what we can actually do. And just thinking back to a couple of cases of patients that I've worked with who have had an ACL reconstruction, we've kind of worked through that process, and it depended a little bit on their inherent disposition. One of the people that comes to mind was inherently really cautious and a little bit fearful. So I was trying to pump him up a little bit, but still affirm that, hey, this caution is good. It's helpful for us, especially as we get you back into doing these activities, these sports, because we haven't tried them out yet. And that prevented him from, he played ultimate Frisbee, and he would not put himself in situations where he'd have to really work hard to get after a pass or be battling somebody else for position, until he had a number of games and a bunch of hours of experience under his belt. And we had been able to kind of field test the stuff that we'd been working hard on in the clinic. And as that happened, then he was able to kind of open himself up a little bit more and not worry so much, because we knew what he could do, or at least more of what he could do.
Yeah, and I think that's a really great point. It really kind of brings up this idea of return to sport being on a continuum. So it isn't a one point in time thing or a decision that, toward end stage rehab, there should be incorporation of sport specific activities, and even some level of sports participation, which then transitions into return to sport. But there still is a big gap between return to sport and return to performance too, that I think is challenging to evaluate as a clinician sometimes. But I think it's a big part of this puzzle. And so you're basically alluding to, in incorporating training and exposure to these activities that, makes these athletes better able to adapt and, do what they need to do in their sport in a very unpredictable environment, which is very different than what typical rehab looks like for these patients, which is very, kind of closed environment and
discrete,
predictable, and exactly. And participating in sports is almost always the opposite of that. And so I think figuring out ways that can be incorporated in late stage rehab and throughout that transition is really important.
That begs the question, are we discharging too early? Are we not giving them enough exposures within the clinic or within a more athletic setting, and kind of throwing them out there a little too early. And then to kind of follow up on that, Matt, if you could, were any of these kids in the study part of a continued training program or anything after the fact that was led by you or by themselves? Was that possibly an indicator of return to performance?
Yeah, that's a great question. We do track these kids over time. To my knowledge, and I would have to kind of dig into these data a little bit. I'm not really aware of any that participated in kind of specific, second injury prevention type activities or training. Most have a kind of gradual transition back to sport, and we see them over time. And they, generally speaking, kind of like we saw in the study, either are able to successfully resume, they decrease their sports participation over time, or they have an additional injury. But I think it's a really important question that, what these athletes engage in outside of, practice and games and the testing that we do may have an impact. And we don't really know what that is. And that, I think, is one of the inherent limitations of an observational study. We try to collect as much data as we can, but we can't really comment on causality here, only association. But I think it's a really great question. Going back to your first question, which was about, are we releasing them or clearing them too early? I think this is a really important discussion. So, we saw that at least in this cohort, most of them are getting cleared on average. Again, this is just an average, but on average at about 8 months. We know from some longitudinal work and research from the Oslo Delaware cohort, which the first author on this paper is Hedgie Grindum. It's published in the British Journal of Sports Medicine. They looked at how time to return to sport was associated with risk of second injury over time, as well as what factors were related to this. And they found that there was, for the first 9 months, every month that was delayed, there was a reduction in risk until 9 months. And that strength was a factor that was related to reducing second injury risk. So I think that time plays a role, but I think we need to be careful and not just evaluating time. So I think that there are biological considerations from a graft integration, kind of what we might kind of call like a joint homeostasis perspective. We have this injury to the joint, we have surgery, we have a graft placed in the joint that's healing either, with bone patellar tendon bone grafts, bone to bone healing, or you have these plugs placed in this hamstring graft. But, that's not a ligament. And so we have this process of kind of ligamentization over time. And what factor does that play? These patients have an effusion in their knee. Obviously, we know about the impairments like strength and other things. So all of this is, all of these factors are kind of interplaying together over time. And it takes time. So it takes focused intervention, but there is still a time component. So I think we need both. But I think where we're trying to get away from is just making that decision based on time. And so there have been several systematic reviews over time that have shown that when we look at what factors are used to clear patients for return to sport after ACL reconstruction, far and away, time is used most often. By far, and then we see these other objective measures. So I think just evaluating and testing even these basic measures and having some level of comparison to norms or to the uninvolved limb is better than the majority of work that we've seen published, and probably to some degree a lot of what we see in clinical practice standard of care. So again, I think time is a factor, as is strength and movement and knee-related function, as is psychological readiness, and a lot of other things that we're not measuring too.
Yeah, there's another paper that when I was digging into all your stuff earlier, you used LSI and you used the hop tests as your objective measures for clearance. And then obviously time was in there. And of the people who had been cleared, I think it was 13.9% of the people who had clearance had actually gotten past those two strength tests and the hop tests.
Yeah.
And that was a startling number for me to think that, 87% of people didn't pass a lot of objective measures before kind of taking that leap back into sport. And it does point to time being obviously the biggest factor. People go, oh, well, you're 9 months out, then go ahead, do your thing. But if you're not prepared, which is preparation is one of the things we talk about on here a lot, are you really ready?
Yeah. So that was a study that was also published in JOSPT a couple of years ago. Allison Toole is the first author on that paper.
Yeah, I think it's 2017 or 2015, something like that.
2017, yeah. We were curious to see kind of, a similar question, but to see, we know what are, at least kind of generally speaking, return to sport criterion that are at least recommended, which what we evaluated in that study were, how many have a patient-reported, function score above 90 out of 100, how many have limb symmetry indices for hop test and strength above 90%. We looked at those all individually and then all combined.
And that was quad and hamstring too.
Yeah, quad and hamstring. And so what we saw was, like you mentioned, only 13 or 14% of, I think, about 120 young athletes in our cohort met all of them, even though they were, again, on average about 8 months out. So I think it really does speak to time is a factor from a biological and a healing standpoint, but time isn't going to ensure that these patients, are able to restore adequate strength and function. And so again, I think it speaks to, again, because we don't in this cohort control any of the rehab or return to sport decision making, it really is kind of a snapshot of what is current clinical practice and decision making. And I think that finding, just like you said, it was kind of startling to us too, to see that. And that's been replicated or shown in a couple of similar studies since, which have found somewhere in that neighborhood, basically 15% or less of these cohorts of patients that have been cleared after ACL reconstruction are meeting even these standard thresholds or benchmarks that we have kind of established. Not even taking into consideration the fact that, as we talk about in the paper we're discussing today, some of the issues with limb symmetry indices and how the uninvolved limb might get negatively affected as a part of the injury or rehab or detraining or being out of sport or whatever that might be. Even when we don't consider that, we just look at limb symmetry indices, very few patients are getting to these thresholds.
Mm-hmm. We talked with Mike Raymond a little bit about that. It was a lot of these studies aren't using the return to sport battery of tests. They're using time as the main criterion. And then that's that piece of the puzzle. And then the other piece of the puzzle is that when we are using those battery of tests, not everybody's passing them and they're still getting cleared. So you have this kind of twofold issue here. Was one reason why I liked your paper so much here, because at least we know that all the participants got the same tests and we could track that going forward. Did you guys, just out of curiosity, did you guys test at the 1 year mark after return to sport? Did you retest some of these things?
Yeah, so we do. So we, at regular intervals, test these clinical measures, strength, hop test performance, and function. So those data weren't included in this paper, but we do see over time, so over the first year and over the second year, that their strength and function does improve over that period of time. But unfortunately, again, we're still seeing that a lot of them are having suboptimal outcomes, whether that's, they're not able to return or they're having second injuries. And so I think what that speaks to is, there is some threshold level that we need to get them to early for them to have success over time, even if they're continuing to improve over time.
Were there limb symmetry indices above, let's say just isokinetic strength testing here? Did they get to that 90% marker, these groups, or at least the group 1 and 3?
Yeah, so you know what? That's a good question. Are you talking about at the time of like the initial testing visit?
Yes.
So, I don't have, I would have to go, actually, I can tell you. Let me look in this table. I'm trying to remember what the values were. Yeah. So actually, when you look at their limb symmetry data, which is in table 2 in this paper, when we look at strength symmetry, all 3 groups are right around 90%, on average at least. So some are below and some are above. And similarly for hamstring strength, most are above 90 and even 95%. So again, there are a portion of them that are below these thresholds, but on average, they're pretty close to meeting some of these measures individually. But again, I think what we see, and going back to the tool paper that you mentioned, is that when we look at a battery of tests, very few people are meeting all of them. So it, I think, really supports the idea of testing in a multifactorial nature, evaluating different types of measures of knee-related function, patient-reported, psychological readiness, strength, performance, movement, because performance on one doesn't necessarily indicate, adequate performance on another.
With that point, can you talk a little bit about the limitations of a limb symmetry index in general? You've alluded to this a little bit, but why are those important historically, the data behind those, but also just limitations with them that clinicians should be aware of?
Yeah. So this is a really big discussion in ACL reconstruction, rehab, and return to sport decision-making right now. I think one study that really highlighted kind of what might happen to the uninvolved limb over time from, early after injury or early after ACL reconstruction until they get, kind of progress throughout rehab toward the time of return to sport or even further, was a study that was published by Liz Welsant, also in JOSPT a couple years ago. And I think the title of that study was like Limb Symmetry Indices Underestimate, uninvolved limb performance or something along these lines. And basically what they did in that study is they had a cohort for which they tested both limbs prior to ACL reconstruction, and again at the time or around the time of return to sport clearance. And so they looked to see if they calculated limb symmetry indices for the involved and the uninvolved limb using the uninvolved value at the time of return to sport, basically kind of characterize what that looked like. And then if they took the uninvolved limb value from back, shortly after their injury, those limb symmetry indices were a lot lower. And way fewer patients met the kind of 90% threshold if the uninvolved limb value was the one that was used shortly after their injury. And so I think that finding was really eye-opening for a lot of people to see what the potential for either due to bilateral kind of neurologic injury effects or detraining, by being out of their sport, or focus on kind of, single limb or injured limb kind of rehab, the effect that might have on the uninvolved limb. So, if you imagine in an ideal world that the uninjured limb performance and strength stays the same and the injured or reconstructed limb kind of over time comes up to meet it, that's the ideal use of a limb symmetry index. Unfortunately, it doesn't seem like that is always the case. So you might have this scenario where, throughout rehab, the involved limb is getting stronger, but the uninvolved limb is maybe coming down to meet it. So you have a symmetrical, patient who has symmetrical strength or performance. But the analogy that's sometimes used is like, riding a bike with two flat tires. So you restore symmetry, but this athlete is not to their pre-injury capacity, whether that be strength or functional performance or whatever it might be. So there have been several studies to kind of show this same thing, that the uninjured limb over time, if not, specifically addressed alongside the involved limb during rehab, might lead to this scenario where we're underestimating the capacity in the involved limb by comparing it to the uninjured limb. And so I think that is the inherent potential concern with just the use of limb symmetry indices. And so I think that supports also evaluating and comparing the function of the involved limb to other reference points. And so that might be comparing their normalized strength or peak torque to some age or sex or sport matched norms, to know, are they where their non-injured peers are that play similar sports and that are of, the same sex and age. Also, if there's an opportunity to test the uninjured limb early in rehab, even if clinicians aren't seeing patients, for prehab or something, like if you're not seeing them between injury and ACL reconstruction, even if you're seeing them shortly thereafter, if there are some measures of the uninjured limb that you can test early on, that might be a good benchmark to come back and compare the injured limb to over time, just as a kind of practical consideration for these patients. Trying to remember where else I was going to go with that, but I think those are the concerns with limb symmetry indices. And if I can make one caveat to say, all that said, we also have a lot of evidence to support that getting people to certain thresholds just based on limb symmetry is important. So I don't think we should throw it out the window. I think we should recognize the limitations in the use of symmetry measures, particularly in cases where there's a decline in uninvolved limb strength or performance, but also know that we have a lot of evidence to support the use of limb symmetry indices, whether that's strength or hop test performance, on outcomes over time. So it's a good discussion. It's important to recognize, but we also shouldn't, on the flip side of the coin, assume that limb symmetry has no effect or no importance either. So
you touched on a follow-up question that I had was, should we also factor in absolute peak values? And you mentioned that perhaps comparing to some age-matched norms or population-matched norms, and then with the results of the current paper here showing that perhaps absolute values are important as well, just another factor to consider. Do we have these norms to compare to yet? Is that something that we're working towards?
So there are some data sets of sport-specific, I know for sure, single leg hop test norms, potentially strength. I have those references somewhere. I can send them to you if you want to, post them somewhere or something. I have to dig in to remember exactly what those are. But yeah, I think that using a decision-making paradigm that incorporates symmetry, incorporates training and evaluating absolute performance as well, whether that's absolute strength, absolute, jump performance, like you indicated, Quinn, in this study, our findings that differentiated these groups were only based on normalized absolute hop performance and no other measure, and not symmetry. And so this, again, like we talk about a little bit in the conclusion of this paper, it may indicate that we need to focus on training bilateral absolute performance and evaluating it and comparing it against some kind of reference value.
You guys have been doing the. You mentioned doing a study since 2007. You're referring to the ACL relay work that you guys are doing there? Can you explain what you're doing with that? And are you taking a lot of subsets in this data and making kind of these analyses like in this current paper, and what we can expect and look forward to in the future from that?
Yeah, that's a great question. So this is an ongoing prospective cohort study where we follow these young athletes over time after ACL reconstruction. Like I mentioned earlier, we follow them standardly to 2 years, where we're testing them at regular intervals. And then in a sub-cohort, we also brought them back 3 years after their 2-year testing visit. So basically 5 years after the time of return to sport, and retested them, as well as did knee MRIs to evaluate their knee cartilage. Some of those data have been published. A lot of this longitudinal work has been led by Laura Schmidt. So I've just kind of been lucky to have been involved with it during my PhD and to continue to collaborate on this project. But, you know, you're right. It is a longitudinal project that has been ongoing for 10 years. And so I think that raises some questions about, have ACL reconstruction rehab practice patterns changed over time? Were the early patients the ones that were doing, really poorly, and then the more recent patients doing better? We have looked at that a little bit, and we don't see that that's the case. So when we look to see, how many patients are meeting strength thresholds or meeting, hot performance thresholds, if we look in, group them over time, or we look in quartiles of time, like the first 4 years, the next 4 years, so on and so forth, we don't really see differences, which is maybe slightly discouraging that the message isn't getting out there, that that practice isn't changing. But I think, we're building, hopefully, a body of evidence that is telling the story. And I hope that through avenues like this, podcasts and other, social media distribution, that we get this information to clinicians to say, this is what we're seeing, and these are areas that we can really improve, or these are things that we should really focus on measuring or testing or evaluating in these patients.
To give some context on some of the numbers that you gave in the introduction of your paper, it was on average at all levels of sports, and not just competitive sports, a little over 60% return to pre-injury levels, and that's recreational. That's what they were doing before. For competitive level sport, it was 33 to 55% ish, something like that, which is consistent. You guys actually found 59%, so 70 of the 124 athletes that you guys looked at made it, but that was still only 59%. Of the athletes returned, or 56%, returned to their pre-injury levels. So to the point that you just made, we've still got a lot of work to do, but maybe we're in that conscious incompetence phase where at least we're, like you said, we're spreading the word and creating awareness. And it's obviously a slow process to kind of gain momentum in this direction, but I think things are certainly looking up. What else can we expect coming down the pipeline from you, whether be it from that particular longitudinal data or what you got going on?
Yeah, so I think what you'll probably see in the near future out of this ACL relay cohort study is continuing to look at some of these longitudinal data over time. So these patients that we test out to 2 years and out to 5 years, what are early factors that are associated with, who has even longer term success. So we published a study a few months ago that was looking at some of the imaging data. So we looked at early cartilage change. So basically we have MRI measures that can evaluate changes in the matrix of the cartilage prior to them developing radiographic osteoarthritis, for example. And so in this cohort, we brought them back and did these MRIs to see, are there factors early, at the time of return to sport or shortly thereafter that are associated with who starts to develop early kind of subclinical signs of osteoarthritis versus not. So I think you'll see some of those data continue to be published, as well as we are doing some work toward trying to develop clinically relevant second injury kind of screening tools, particularly as it relates to movement assessments. So hopefully some of those data soon. They've been presented recently at CSM and whatnot. So I think those are some of the upcoming things to look for from this ACL relay cohort study. And then for me specifically, since I've been down here at UAB, we have also, working with Mark and Laura, started to do some work looking at novel ways to try to target late stage rehab interventions for these patients. So thinking of ways that we can specifically target muscle performance in different ways, whether that be through force development capacity in the muscles versus kind of velocity dependent measures. So we know that things like rate of torque development is another big problem for these patients, not just how much force can they produce, but also how quickly can they do that. Power is the key factor in almost every sport-related movement, which encompasses both of these items. And so I'm starting to do some work looking at that. So some things along those lines, trying to figure out ways that we can really target rehab interventions, especially late stage, for these patients. So that may be on the horizon. We'll see how it goes. But we're kind of in the pilot stages of that work right now. So
that leads me to a question that thankfully you're doing that kind of work, because it does lead me to this question. What do you say to clinicians in that late stage phase who have a fear of re-injury in the clinic or pushing their athlete too much or doing too much in that late stage? Because there is a lack of power development and lack of strength in a lot of those late stage discharges. What do you say to those clinicians?
I think we need to push these patients early and hard. I think that we need to build a base capacity of strength or, whatever it is. And I don't think that we, speaking generally or on the whole, do a great job. And this is obviously isn't targeted toward anyone or any place, but as a profession overall in these patients, do a good job of creating sufficient stimulus for adaptation that's needed. So loading appropriately and programming exercise effectively, I think, are big issues that are even outside of this very specific idea around, how do we kind of better target force versus velocity related interventions. I think throughout the course of rehab, we build capacity to make them successful with some of these late stage interventions. I think having progressive exposure is important. Moving them from a more closed to a more kind of open environment where they're having to make decisions and respond and react, so that when they get on the field, they're able to do that, or that just happens intuitively. So I think it comes down to building capacity adequately and then allowing these athletes to use it, control environments, and transitioning them toward environments that are going to be more similar to what they see on the field. I think there's also some opportunities for some really cool stuff related to neurologic adaptations due to ACL injury and some novel interventions in that space. If you guys get a chance, I'm going to plug him because he's my friend. If you get a chance to get Dusty Grooms on here, I would 100% recommend doing so. I don't know if any of you have seen him speak, but he's doing a lot of work in this space around neurologic and neuroplasticity and neurologic adaptations to musculoskeletal injuries, mostly ACL injuries, how that might affect late stage rehab intervention. So, I think there's a lot of potential opportunities for us to get better. What I think some of our work is highlighting is that even the basics, restoring strength symmetry, testing and measuring these things are areas that we overall as a profession can improve for these ACL reconstruction patients.
So then after that, what advice would you give an athlete or the parent of an athlete who's been discharged and wants to get back to sports after pouring through all this data that you have tons of?
Yeah. So, I mean, I think education throughout is really important. There is still this expectation that ACL reconstruction and rehab is going to be 6 months and people are going to be back to sport. Despite a lot of data showing that, recovery takes longer, people aren't meeting or getting to, sufficient strength and performance and functional thresholds by that point in time, that early return is, potentially a risk factor for having additional injury. So I think having clear communication throughout the course of rehab, but especially early on, as far as expectations, is one thing. But I think you need to be clear with people that, this is what we know. There is a high risk of having additional injury. We can't predict if you're going to or not. There are a lot of factors that contribute to that. But what we can do is get you to, to a level or to a threshold that, to the best of our knowledge right now, mitigates that risk to the best of our ability. But I think there's always going to be risk with return to sport. There, to some extent, is, risk of injury in playing any sport, but particularly if we focus in on ACL injuries and returning after having one, that risk is way higher. So I think, again, we have a lot of work to do to really hone in on what are the best, the most sensitive, the most predictive criteria that we can use to help make this decision. But we do have at least some evidence now to help in this decision. So I think it really starts with testing, knowing where these patients are, objectively testing. So, testing strength with manual muscle testing isn't enough in this patient population, as is doing some kind of a closed chain strength test where they can, in the example of quad strength, compensate or avoid loading their knee or their quads. So I think we need objective measurements of strength and performance for sure, and at least ensure that these patients are getting to some of these thresholds.
What's awesome about you, Matt, is that you're doing the research and you're also a clinician. So you see these things from both sides. Those kids are so lucky. Those kids that tore their ACLs are so lucky to have you. Will you?
I'm so flattered.
Yeah. I want to tear my ACL and then I'm going to fly to Alabama. So
don't do that.
Okay.
Wow.
It's okay. I don't run and cut hard enough or fast enough to subject myself to those forces. When your new stuff starts coming out, and will you consider coming back on the show to talk about that?
Yeah, for sure. Anytime. This is fun. This is a cool forum. And from what I can tell, audience, because it's not just clinicians. So, we think about return to sport and all of the players in this process, all of the, quote unquote stakeholders, from the patient or the athlete first to the clinicians to obviously the athletic team as well, whether that's, performance, strength conditioning, coaches, so on and so forth. So there are a lot of stakeholders in this process. And I think being able to get this information to more than one audience is really important, to know that there are a lot of factors that go into this decision, that there are a lot of stakeholders, and that this decision and this process, again, isn't a finite kind of one-time thing, and that there should be multiple people involved in the decision. So I think shared decision-making is a really big piece, coming from all of these different stakeholders and, things to evaluate. And so I think reaching all of them is cool. So
thanks so much for being on the show. This was awesome. I learned a ton hearing you talk. Where can people connect with you? Where can they find more of your stuff? All of that.
Yeah. So from a social media perspective, professionally, I'm primarily on Twitter. So my Twitter handle is first name, last name, Matt Ithurburn, PT, all together. So that's where I'll usually put most of the stuff there. We've been kind of trying to purposefully think about ways that we can communicate this science and these research findings in the most kind of easily read and packaged format. And so we've been trying to incorporate a lot of different approaches to that, infographic creation and stuff, and pushing a lot of that stuff out through social media, which I think it's been really effective from a communicating the message and exposure standpoint for some of this work. So most of that stuff I'll push out on Twitter. So
awesome. And before I forget, I actually saw Dusty Grooms speak at CSM this past year, and just blew my mind.
Yeah. So get him on.
Okay, we will. That's actually yeah. There you go. Perfect. Again, thank you so much. This was awesome. We would love to have you back on the show again, and hopefully maybe we'll have 7 listeners, and the word can spread to even greater audiences.
There you go.
Yeah. Thanks again, Matt.
Maximizing impact, right?
There you go.
Thanks, guys. I appreciate it.
Absolutely.
Thanks, Matt.